Ari, ballpark, like how many, not excluding like creation and abandonment, but like fistulograms and declots, ballpark in a week, how many will you guys do?
So we are averaging, because we're still in the main OR, so we're HOPD. We in the main OR will average anywhere from 35 to 50 cases in a week in the main OR.
All right, Omar, same question. How about you?
We do roughly, I'd say 12 to 14, cases a day on average. Yeah, I do the math, and it just depends. Some days you'll be short cases, and the next day you get overwhelmed. And I should have mentioned too. So yeah, we opened similar to the reason Ari opened back in 2007. I did my nephrology training fellowship from 2003 to 2005 here in Memphis, and during that time, that's where we realized how urgent the need for AV access was. All our patients would mostly come to the hospital for any issues, catheter exchanges, AV, angiograms, declots. Stuff that's done now in an outpatient setting was being done in the hospital with a hospital admission. So those patients were, taking up resources when, urgent cases came in or emergencies. Our patients was often get kicked kind of to the side. And they may be in the hospital a week for a catheter exchange or even a declot. So one of the reasons we opened is we knew the need was there to get these patients dedicated care that they deserved and needed, move that out of the hospital so that they could have the resources to do what they needed. But also these patients, we were able to take care of them in a prompt, quick manner, which in the end, it saved the patients time, and it also saved the healthcare system, healthcare dollars.
Yeah, I think about like how important that is to not come into the hospital and then your declot keeps getting bumped because, and sometimes reasonably so, because there's a limited number of hospital resources. And if someone gets a dialysis catheter, they can kind of limp along, but it's just so much easier to get to the declots quicker, get the patient out and back like to their normal life. It's just a shame that, a week wait time for a declot, that's awful. So congratulations to both of you. But what I wanted to paint for the audience is we have two operators here who are doing a lot of cases, in short. All right, so what I wanted to start with is basically your algorithm. We'll start with Omar. Basically, Omar, I would just like your algorithm. Like if you're coming up on a fistulogram, like referred for outflow, what you consider outflow symptoms, how you would approach it, and just like walk us through like, a regular case. And you can make it whatever case you want, but something like basically outflow issue, not like a balloon maturation or anything.
So a common case like today would be a patient that's having prolonged bleeding and high venous pressure. So we get a call from the dialysis unit. This patient bled 15, 20 minutes after their procedure. And that's the bleeding I'm talking about is when a patient dialyzes, you have to insert two pretty hefty 15 to 14 gauge needles into the patient's access. And after dialysis, these needles are pulled. And you just like if you had your blood drawn, you put a little 4x4 piece of gauze over it and hold light pressure for it to stop bleeding, which usually should occur. Or you would say, what, about 3 to 5 minutes should be normal?
Somewhere in there,
yeah.
Up to 8.
Yeah,
sure.
Up to 8 minutes. But when you go 20, 30 minutes, an hour, that there's something wrong. And usually that's a sign of increased pressure within the access. And if you have increased pressure in the access, that's going to make it hard for those platelets in the blood clotting process to complete. All right. So we'll get a call. The patient will come into the office. We will do a physical assessment, which requires us looking at the access, laying our hands on it, which usually gives us an indication. It lets us know pretty quick that there's an issue. Some of the findings are the access is pulsatile. And when we say pulsatile, we're talking about the quality of when you palpate the fistula. If it's pulsatile, that means it's just a hard throbbing, just like if you put your finger on your wrist. And once we establish that, we'll take the patient to the back and perform an angiogram.
Does any of your patients, do they get pre-procedure ultrasounds?
Yes, and I should mention that. So we do what's called a flow study. We have an ultrasound machine where we measure the flow in every patient that comes into our center that has an access. The wonderful thing about the outpatient center, just like primary care doctors, we have established patients. So I would say 90% of our patients that come in, 95, are established patients. not new. And we usually have a baseline flow study on them. So let's say their fistula flow at baseline, which is after a procedure where it's normal. The flow should usually be between, we like 600 to 1200 mLs per minute. And if their baseline is 1,000, then, and they come in that day 3 months later, let's say 3 months after we did the index procedure, but for prolonged bleeding or high venous pressures, and we get a flow now of 500 mLs per minute, which is half of what it was. That is a sign that the flow is slowed up, usually because there's some sort of outflow obstruction. Just like on a highway, if you have a car wreck and you're trying to get home, that's an outflow obstruction. Pressure, traffic's going to build up, and the flow of the traffic's going to go down. Fistula does the same thing. The flow goes down. And so physical exam, right, the complaint and the volume flow gives us kind of just compiles that data and validates that there's a problem.
Got it.